basic surgical science. It is pathology. In England, pathology is including and microbiology and even parasite. So you can find they ask you about something like infection and all this. Usually in exams, they give you scenario, this little scenario. This scenario is like 65 years old man, complain of painless hematuria, abdominal CT show renal mass, blood picture show polycythemia. The examiner will ask you some question related to this condition. Okay. Usually the question is just a simple question and easy. So we start one by one. Anyone need to start? So any volunteer first? Anyone, just don't be shy. It is just a good experience.
Hi, doctor. Can I try?
Okay, yeah, can. All right. So you
Hi.
read the scenario first. After you finish, I will ask you.
Okay. A 65-year-old man complained of painless hematuria. Abdominal CT shows renal mass. Blood picture shows polycythemia.
Okay. So are you ready? What's your diagnosis?
My diagnosis is renal cell carcinoma due to the presence of renal mass and polycythemia.
Okay. So what is polycythemia?
It's increase in number of red blood cells.
Okay. What is number of RBCs?
The normal is 5
million
to 10.
or 5 times 10 or something like that. It is 5 million. Okay. So what is the cause of this polycythemia in this patient?
Increase in erythropoietin.
Biotin. What is erythropoietin?
It's a stimulus for red blood cell growth.
Yeah, it is hormone secreted from which part of kidney?
Oh.
It is secreted from the peritubular cell of the kidney.
Tubular.
Okay.
Peritubular cells.
Yeah. If you have all the book, in all the books, they call just a glomerulus apparatus, but now it is peritubular cell. Okay. So I ask you, what is your diagnosis? It is renal cell carcinoma. Patient have mass, painless hematuria, and polycythemia. And polycythemia is increased number of RBCs due to increase erythropoietin. What other causes of polycythemia? Physiological cause of polycythemia.
Living in high altitude.
Yeah, living in high altitude and smoking and hypoxia. This can cause of polycythemia. Is polycythemia dangerous?
Yes, it predisposed to a DVT.
What is DVT? Deep venous thrombosis.
Deep vein thrombosis.
What is thrombosis?
It's clot of blood.
It is occlusion of the blood in living. Clot is if it is outside the body. So it is occlusion of the bloodstream by some of blood constituent. What is embolus?
Embolus is a free-flowing clot in the bloodstream.
Can be detached thrombus or can be what else? Okay, thrombus can be embolus, can be fat, can be amniotic fluid, can be air, can be foreign body, can be detached thrombus. So again, we speak about thrombus. So you mentioned DVT is deep venous thrombosis, and thrombosis is occlusion of the flow of blood vessels in living by thrombus. So what is the pathogenesis of the deep venous thrombosis?
It can be explained by the Virchow's triad, consists of endothelial injury, venous stasis, and hypercoagulable state.
Okay, so what is the prophylaxis against deep venous thrombosis in general in surgical patient?
It consists of preoperative measures, intraoperative measure, and post-operative measure.
Okay,
Preoperative measures
preoperative like what?
Ensure the hematocrit level is not too high by providing adequate fluid.
Usually, we
Make the
why what
patient
is
wear
the
the
patient
compression socks.
wear TED stocking or the gradual compression stocking, avoid dehydration. So during operation, what else you added to avoid deep venous thrombosis? We have pneumatic compression or pneumatic intermittent
Oh,
compression.
okay.
Post-operative, we ask the patient or encourage the patient to walk early, well
Mop
hydrated,
up, early
and
mop
if
up.
it is a risk patient, we give him the Clexane or anticoagulant. If patient can drink, so can give oral anticoagulant. If not, we give him low molecular weight heparin or heparin. What mechanism of action of heparin? In which pathway heparin act?
Heparin act on intrinsic pathway, inhibits the factor 1, 2, 9, and 10.
Okay, what is the heparin antidote?
Oh no, that's warfarin.
No,
Protamine sulfate.
protamine sulfate. Okay. How to monitor heparin in the patient? How to monitor it?
APTT.
Yeah, activated partial thromboplastin. Of course, our case is renal cell carcinoma because painless hematuria, renal cell polycythemia. Sometimes in male can have secondary varicocele. Sometimes in exam we ask you some question and the answer in the statement itself or the scenario itself. You mentioned Clexane or low molecular weight heparin. What is the dose of low molecular weight heparin?
1 mg per kg over
Yeah.
24 hours as a prophylaxis, and 1 mg per kg for every 12 hours if it's for therapeutic.
All right. Okay. All right. So we left this renal cell carcinoma. We go to the urinary bladder carcinoma. What type of cancer can occur in urinary bladder?
Squamous cell
No,
carcinoma.
squamous is very rare, occur in some
Rare.
country like Japan or Egypt because of the bilharziasis or schistosoma. But the common is transitional cell carcinoma, very rare squamous adenocarcinoma. So it is transitional cell carcinoma. What is the presentation? Usually the presentation of the urinary bladder cancer.
Painless hematuria.
Bell's hematuria, okay, of course, Bell's hematuria is the main of the renal and the urinary bladder cancer or terminal hematuria. What is the risk factor to cause urinary bladder cancer?
Smoking, schistosome.
No, forget schistosoma. We are not living in Egypt. Even in Egypt now, I think is not common. Smoking can anneal dye, beta-naphtholamine dye, chronic irritation can be. Okay. All right. So in the cancer, bladder have unique properties not in other cancer. What you think is this? Like in surgery or something like that? What is the difference between cancer in the urinary bladder, for example, and the cancer colon? I just make it simple. In the cancer colon, you can find malignant ulcer. In the cancer urinary bladder, you can find malignant ulcer. What is the difference in treat malignant ulcer here and here? In the colon,
Bladder cancer is not treated surgically.
no, it can treat it by endoscopic, and you can not remove the tumor itself with safety margin. But in cancer colon, we remove this part of colon because in the urinary bladder they have superficial and deep muscle. So this is important to know roughly the staging of urinary bladder. If you can see here, the staging of the cancer in urinary bladder, we have T2 invading superficial muscle and T3 invading the deep muscle. So till the superficial muscle, we can remove the tumor. We don't remove the urinary bladder. Deep muscle, we need to remove the urinary bladder. So the unique or the difference between urinary bladder cancer and the other cancer, you can have local resection of the tumor if it is superficial. We don't do that in other organ. Second, chemotherapy. In urinary bladder cancer, you can give chemotherapy local, like through the catheter. But in other cancer, we give it systemic or intravenous. So the two difference in urinary bladder cancer, superficial tumor can be excised by endoscope and can give local chemotherapy and sometimes also something called immunostimulant like BCG local. So you can find in the treatment endoscopic resection with chemotherapy or immunostimulant like BCG or adriamycin. Okay. Of course, if fail or deep, radical cystectomy and radiotherapy. Okay. You got the point? So staging of cancer bladder, we have superficial and deep. So this is the difference between T2 and T3. I know that if you are in urology, they have subdivision like T2A and B, but it is not important to us. But it is mean superficial and deep, and the treatment is excision if it is superficial, followed by chemo local and immunostimulant local if it's deep or recurrent. So you need to remove the organ. Okay. Thank you. Okay, thank you, doctors. We have another scenario. Any question for this about renal cell carcinoma, urinary bladder cancer? Anyone have a question? Okay. So we go to the second topic. Second topic is 45 years old man, chronic alcoholic, suffer from severe epigastric pain, radiated to back, serum amylase is elevated, blood glucose is high, although the patient is non-diabetic. Okay. Of course, before you enter the station, if you see this, you make the diagnosis. But of course, it is a pathology station, so you ask you in detail. So anyone need to share?
Good evening, Dr.
Good
Shakir.
evening. Yes, you can start. Hi, Dr. Izzeddin.
Yeah.
Okay.
So,
All right.
45 years old, man, chronic alcoholic, suffer from severe gastric pain, radiated to the back, serum amylase is elevated, blood glucose is high, although the patient is non-diabetic.
Okay. So before I ask you the question, why the value we say blood glucose is high, although the patient is non-diabetic? What you think this is written for what? To confirm what?
To confirm that there is hyperglycemia without diabetes. So,
Yeah, it means that you confirm or with the diagnosis of what? What's your diagnosis?
acute pancreatitis.
Acute pancreatitis. Okay. What is the cause of acute pancreatitis in general?
Generally, the patient, alcoholic patients, if
No, in general, not in this patient. I know this patient is pancreatitis because of the alcohol. In general, like all over other patient.
Okay, stone, thrombotic stone, radiation, hypercalcemia, generally patient.
Okay. Can be iatrogenic.
Yes, post ERCP. Yes.
Okay, so acute pancreatitis can be gallbladder stone or biliary stone, can be chronic alcohol, can be hyperlipidemia or triglyceride, can be blunt trauma, which is very, very, very rare, and can be iatrogenic. Iatrogenic like what? Like ERCP. Okay, so what is the test you do it for pancreatitis?
Okay. We do serum lipase. We do serum amylase, even though they are not specific. We can find
Which one is specific?
is the lipase is more specific. Lipase.
Lipase is more specific. What amylase is not specific?
Because it has a period. It's from 6 hours until 48 hours. So after that and before that, it is not high. And it can find in other part of the body, like musculoskeletal or yeah.
No, it is. If you say it is non-specific because it can occur in other acute abdominal condition.
Yeah.
So what other acute abdominal condition you can find the high amylase?
Is it? Yeah, I'm not sure.
It is occur in many disease, like for example, mesenteric vascular occlusion, acute cholecystitis. So this is why amylase is non-specific because it is occur in other acute abdominal case like perforated peptic ulcer, peritonitis, mesenteric vascular occlusion. All these can cause false high amylase.
I see. Okay.
Okay. All right. So what is the radiological investigation you can do to confirm a diagnosis of this patient?
The CT scan with contrast.
CT or ultrasound and CT. Okay. What is the lab investigation you need to do?
You need to do to read the amylase, lipase, of course. You need to do the FPC. You need to do maybe you can perform with LDH.
You saw
Calcium.
liver function, renal function, baseline investigation, arterial blood gases, all these must be done. Okay. All right. So is any prognostic factor you know it about acute pancreatitis?
Yeah, there is two, Glasgow and Ranson.
Which one is easy to remember?
I think Glasgow.
Okay, so in this situation, you take a paper and write pancreas, Pancreas, B for BO2, and you don't need to mention the number, just say it is increase or decrease. Can you start?
Okay, so P is a partial O2 will be reduced or decreased. The age is if more than high age, old age. Neutrophil if it's high, more than
Age usually more than 55. Neutrophil is?
more than 15,000. Calcium if less than 2 milligrams.
Okay, it is important in exam to be intelligent. So don't dig your time or wait or to mention number because maybe by mistake. So just to say the calcium is decreased. Why the calcium is decreased?
Because it after the action of lipase will be this break down the fat and the fat will take the calcium with it. And another one is because
okay, you mean that formation of the calcium soap because of the attachment or reaction of the pancreatic enzymes with the fat in the greater omentum, which is much. What about renal function is?
renal function is high. Urea
Is
is
a
high.
high increase. Okay, and acidosis of liver enzyme.
Yeah, liver enzyme also high.
Okay, liver enzyme is not include amylase and lipase. Amylase and lipase is not in prognostic factor. And after that, A for acidosis mean pH is low and the blood sugar is high. And it is diagnostic if the patient, like our patient, is non-diabetic. Okay, so how to treat this patient?
According to CREST protocol.
What you mean by CREST protocol?
CREST protocol is the
you mean critical ill surgical patient? You think this patient is critical ill surgical patient?
Yes.
No. What is definition of critical ill surgical patient? The critical ill surgical patient must have organ failure. This is not a critical ill surgical patient. Okay. Although I know that the most of the students say that, but it is not correct because not all surgical patient is critical ill surgical patient. Critical ill is different category. Like if can this patient if have ARDS or have a complication can be critical ill surgical patient. Okay. So how to treat this patient first?
So this patient needs to be treated in high HDU. You have to manage his IV fluid, give IV fluid.
First, what this patient come to you? Why this patient come to you?
Because of the pain. So
if this patient, any patient come to you with pain, so the first line of treatment is give analgesia.
Okay. So
yeah. Except in trauma or patient in respiratory distress, you start by ABC, and of course, someone also give him analgesia. So this patient come with pain, so you give him analgesia. So the first line of treatment is analgesic. Okay. Like what?
We usually give here not the opioid. We give the opioid actually.
Say again.
Opioid.
Opioid. What is the route usually you give opioid? It is intravenous drip and usually BCA, patient control analgesia. So the first line of treatment is we give the patient analgesia. After that, you mentioned you give fluid. Okay? How to monitor this fluid?
We by catheter, urinary catheter.
So you mean that by input and output chart, so you put a urinary catheter. Or in critical patients, you can insert central line. After that, what else?
Yeah, we nail by mouth, which will, or we can give feeding by nasojejunal tube. Then, in some cases, we need to do surgery if to do.
No, we don't ask about this. Is pathology station. We don't ask you in surgery. So you need to give patient oxygen or not?
Yeah, of course.
Why? Yes, of course, you must give oxygen monitoring by pulse oximeter. So you give a patient analgesia, intravenous fluid, follow up the fluid by input and output chart or CVP, and give oxygen and followed up by pulse oximeter. So why you give oxygen?
As a supportive, and the patient could have RDIS. So
just to avoid a complication which can occur in the lung. What is this complication can occur in the lung?
the RDIS, acute respiratory distress.
Acute respiratory distress syndrome. Okay. If you give a fluid, we sometimes use something called the fluid challenge test. What is this?
That we give a bolus of crystalloid over 20 minutes, and then assist back after finish of the fluid, and then if still hypotensive, we still give another bite of crystalloid.
All right. So I think it's okay. If it is guided by CVP, so if you give this bolus or 250 within 10 minutes, it can become very high CVP. So it is hypervolemic or become till normal. So it's normal or become below, it is hypovolemic. Okay. So we're still in pancreatitis. What is the complication of pancreatitis?
Okay. The pancreatitis can have pseudocyst, can have hemorrhagic pancreatitis, can have hemorrhagic. What is that? Ischemic.
Okay, so you mean from the beginning in pathology, usually they like to be systematic. So to be systematic in pathology, so we have local complication, general complication. Local complication, something in the pancreas, like pseudopancreatic cyst, acute hemorrhagic pancreatitis, necrosis, obstruction, fistula, and systematic condition or general complication like what?
Yeah, from hypercalcemia, renal failure also.
Acute kidney injury, you mean acute respiratory distress syndrome till multiple organ failure. Okay, so back again. What type of bilirubin if the okay, so what is the presentation of cancer pancreas? It is another topic. What is the presentation of cancer pancreas?
Yeah, if head of pancreas, there will be painless jaundice.
Painless, which type of jaundice? Painless?
Conjugated or
Painless obstructed jaundice and cachexia and maybe thrombophlebitis. What is the prognosis of the cancer pancreas?
is bad prognosis.
What you mean by bad?
That the survival rate in 5 years is low.
Is low, maybe 5 or 10, so low survival rate. Okay, what type of bilirubin is high in obstructive jaundice due to cancer head of pancreas?
Direct bilirubin.
What's the tumor marker for cancer pancreas?
Cancer pancreas is this 119.
CA 19.9.
99, okay.
Okay, tumor marker is very important topic. So as you see here, we started by cancer by acute pancreatitis, and we go to the cancer head of pancreas. We ask about tumor marker. We ask about fluid channel test. We ask about analgesic. So it is important you jump from topic to topic, and this is usually what happened in the pathology exam. Okay.
Thank you.
Thank you. Is anyone enter exam before in pathology? they have this station or mimic this station? Or what is your opinion? Okay. All right. So we have another scenario. Thank you, Dr. Izzuddin. Have another scenario is about 67 years old man, chronic smoker, suffer from hematemesis, vomiting of blood, upper G endoscopy show mass in the lower part of esophagus, biopsy diagnosed as adenocarcinoma. Examiner ask you some question. So a lot of knowledge you can notice here from the script. So anyone? Okay, I just someone asked me. Anyone, don't be shy. Is anyone need to be okay? Forward.
Salma is raising hand.
All right. Okay. All right. Okay. So you can start, Dr. Salma.
Okay.
Okay.
Yes.
We can start. Okay. So you can you can go through the scenario again if you have any query.
Okay.
Okay. So what's your diagnosis?
My diagnosis is esophageal carcinoma.
Esophageal carcinoma, of course, it is adenocarcinoma. Okay. What is Barrett esophagus?
It's a metaplasia.
What is metaplasia?
A change in the lining epithelium from one type to another due to reversible cell injury.
What you mean by from one type to another? Which type to another type?
In the esophagus, from non-keratinized stratified squamous epithelium to columnar epithelium with goblet cell.
Okay. All right. So what is cellular dysplasia?
Dysplasia is like a change, damage or change from one type to another type cell.
No, metaplasia is from one type to type. Dysplasia is a malignant cell without invasion of basement membrane. Dysplasia is the early stage of carcinoma in situ. Okay? So it is malignant cells, so they have all character of malignancy. All character of malignancy like polymorphic, deeply nucleated, increased cytoplasmic nuclear ratio, all this can happen. So it is like a cancer. It is 100% cancer, but without invasion of basement membrane. Okay, clear? So, of course, we have this picture. It is Barrett esophagus. So after that, we ask you, what is the possible cause of Barrett esophagus? What cause of Barrett esophagus? Chronic irritation due to what?
GERD.
GERD. What is GERD? GERD is
gastroesophageal
reflux. Okay. All right.
Chronic smoking.
Yes. Spicy food, preserved food, alcoholic. Food. Okay. What type of cancer in esophagus, you know?
Adenocarcinoma, which is most common type, and other types like squamous cell carcinoma due to long-standing irritation.
Actually, squamous cell carcinoma is not due to long-standing irritation. Squamous cell carcinoma is normal in the past, can happen because the lining is stratified squamous. If it is arise from smooth muscle, what we called it?
Leiomyosarcoma.
Leiomyosarcoma, of course. So we have stratified squamous, we have adenocarcinoma, we have leiomyosarcoma. Okay. So what is the macroscopic picture? Macroscopic means gross anatomy of the tumor in the esophagus.
Maybe ulcerative or infiltrative or fungating, but it's common.
Okay, so maybe a mass, maybe a fungated, maybe a stricture. Okay, all right. So what is the method of spread?
By mainly by lymphatics, then direct, then blood.
What you mean by that? To which organ?
To the surrounding,
What is the common surrounding organ related to esophagus is trachea. So can be local to the trachea, can be lymphatic, can be blood. Okay, we're still in the esophagus. So what is the prognosis of cancer esophagus?
is poor prognosis, because when it becomes symptomatic, it's mainly metastatic.
Is a mainly late stage. What mean by poor prognosis? What poor mean? 5 year
5
survival
survival.
is 5-10%, something like that. Okay, we change the topic now from cancer esophagus to stomach. What is the common country have cancer stomach?
Like southeastern, like China, Japan.
Okay,
And
Southeast Asia, like Japan, South Korea, China. Why? Or what is the etiology of the cancer stomach in general?
in general,
Yes.
non-modifiable and modifiable. Is arsenic
What you
genetic.
mean by modifiable and not modifiable? I don't understand
Like
you.
I think like that in non-modifiable, like genetic factors and family history.
Usually with classification of the tumor, we don't have this classification.
Okay.
In the classic pathology, maybe in surgery, but in classic pathology, we don't have non-modified and the modified classification of the tumor. Maybe we can have genetic and non-genetic, or genetic or acquired. Okay. You know, pathology is a classic people, so the classification pathology is the classic way. But okay, so what you mean by non-modified, like genetic, like what?
Family history.
Okay.
Diffuse gastric carcinoma.
Okay.
Catherine.
Okay.
And also previous gastric surgery, antral polyps.
Okay, this is what you mentioned is something common you see in your practice or not?
No, the most common also H. pylori.
Okay, so can you think, doctor, if you are start in the exam in this way, it's easy to fail, because simply he ask you about what is this, because don't say the rare in the beginning. All you mention like diffuse, like B cactins, like antral polyp is common, or H. pylori is common?
Is more common.
Okay, so think for the common thing. Don't put a classification from your background and make it. What is the common cause in general of the cancer stomach?
Chronic gastritis, gastric ulcer.
Okay, chronic gastritis, gastric ulcer, H. pylori, spicy food, atrophic gastritis. All this is the common cause, right? But you mentioned family history can, diffuse can, polyp very rare, but can also. How to confirm the diagnosis of cancer stomach?
Upper gastrointestinal endoscopy and biopsy.
What does biopsy mean?
Biopsy, take a sample and send it for analysis.
Under microscope. You mean take a sample from living, because autopsy is take a sample from dead. So biopsy is take a sample from living. Okay, what type of biopsy you can take it from stomach? What we called it? Say again.
What's the type of biopsy?
Yes, you take a biopsy by endoscope. What is this type of biopsy called?
Incisional.
No, incisional mean incisional. This is punch biopsy.
Okay.
Okay, so you take punch biopsy. If it is open surgery, it is called excision biopsy. Okay. All right. So this is first. So we're back to your condition. What is method of spread of the cancer stomach?
Local and lymphatics and the blood.
And another one is specific for stomach and ovary. What we called it?
Transcelomic.
Transcelomic or Korkenberg, okay. And usually it is adenocarcinoma, okay. You mentioned before that congenital, what is called hereditary diffuse gastric ulcer.
Yes.
What is this?
It is a type of cancer that like due to presence of genetic predisposition, which is E-cadherin gene.
E-cadherin. Okay, all
Yes.
right. I don't ask what is E-cadherin, no problem for me, but okay, because maybe difficult. All right, so it is common in which country?
Japan and
Japan.
Southeast.
What age we can screen these people?
We can start from age of 16.
Okay. Okay. So in your experience as a doctor, is any country make screening for people at school age which is 16?
No.
Okay. So you found it is logic to make a screening for people at 16. And what is the method of screening you make it at 16 age?
In Japan, they do upper endoscope.
Okay, so you think that we can bring the student or young people to make OGD or upper endoscopy in Japan? You think that it is true? You think it is logic or unlogic?
Unlogic.
Unlogic. So if you say in exam something unlogic, we consider if this question is out of 1 mark, we don't give you 0. We give you -4. So how it come in 1 mark, we give you -4?
Because it's not logic.
No, because we have professionalism, have 4 numbers, so we remove it from the 4. Okay? What you mentioned is not wrong, but it is oncogenic, what is called oncogenic study, oncogene study. Oncogene study you can done in age of 16. Oncogene study is like ABC oncogene. But this oncogene study is not a screening. You know the difference?
Yes.
What you mentioned, it is correct. It is correct for oncogene study. Oncogene study is not a screening. Screening mean you make something in the population like mammogram in breast or fecal occult blood in the cancer colon. But if you need to make a screening for the hereditary diffuse gastric cancer, you make it at age of 30 and 40 in the people or the family have the family history of the gastric cancer below the age of 40. So this is a screening by OGD. What you read in some books, it is not a screening. It is what is called oncogene study. Oncogene study is not a screening. I know that it is written in the most book is 16. 16 is not the age of screening. You can, you know, I tell you the idea. Suppose one patient or one female have a cancer breast, and she need to make the oncogene study to her daughter or her mother. He can do at any age. You got the point?
Yes. This is 16.
No,
If
this
it's
is not a
specific.
screening.
Okay.
You understand the idea?
Yes.
It is not a screening. What you mentioned is the oncogene study. Oncogene study is not a screening. A screening is do a test for all population, and the screening tests have an idea. Must be common disease, must be cheap, must be not harmful, must be simple, must be highly positive, and more specific and high sensitive. Okay? All right. So it is very common. We heard about this in the exam. And it is very wrong answer or unlogic answer because you have misunderstanding between oncogene study and screening. Okay? You get the point or you don't understand me?
Yes.
I know
I
that
get
it
the
is in your book and in all books. I know that but they have misunderstanding between oncogene study and the screen. So this is why I ask you. If you come in exam, the examiner asks you in the same way I ask you. All right, so back again because we have a time. All right, so what is cause of peptic ulcer? We're still in the same station. What is the cause of peptic ulcer?
Non-steroidal anti-inflammatory drugs, the chronic H. pylori infection.
What is H. pylori?
Also, it is gram-negative microaerophilic.
Terminal flagella, urine producing. Okay. How to diagnose H. pylori?
Spiral bacteria.
Yes, how to diagnose it?
By flow test. By
Flow
taking a tissue biopsy
test,
from
yes. Flow test is a Campylobacter-like organism. This is the flow test. It is the dye. They change it from orange to become red. Okay. So how to treat it?
By giving a full dose of proton pump inhibitor plus 1 gram of amoxicillin plus metronidazole.
Okay, so
For 7
metronidazole
days.
and clarithromycin. So, all right. So, what is other disease can cause by H. pylori?
May cause maltoma, mucosa associated lymphoid tissue.
Mucosa associating lymphoid tissue. All right. Okay. All right. So, what is site of peptic ulceration usually?
Mainly at the antrum.
Okay, okay, and it can be anastomotic peptic ulcer, can be in Meckel diverticulum, which is rare. What complication of peptic ulcer?
Perforation and malignant transformation, mainly if it's gastric.
Okay, and in benign lesions, it can be gastric outlet obstruction. If patient have gastric outlet obstruction, what's the arterial blood gas picture?
If what? I didn't
If the patient have gastric outlet obstruction, pyloric stenosis, due to cancer, due to ulcer, whatever the cause, what is the arterial blood gases picture?
He has metabolic alkalosis.
Metabolic alkalosis and
hypokalemia. And hypercholesterol.
What mean by hypercholesteremia? What you mean?
Hypokalemic, hypercholeremic, metabolic alkalosis.
What mean by hypocholoremic? What you mean?
I mean that due to loss of chloride.
No. You mean that high chloride?
Yes.
In your practice, you ask for chloride, doctor?
No.
Okay. If you something you don't ask in your practice, don't tell us in exam. This is why it is easy to lose a mark because you say something is not practical. I say it is correct, but it's not done. In your life, suppose you are working for 5 years, you ask about chlorine?
No.
Okay, if you don't ask, don't tell us an exam. This is exam is what you do, not what is written in book. All right, so this is easy we found some student is easy to pass and some student is easy to fail. Okay, you got the point? All right.
Yeah.
So we finish this topic, we speak about ulcer. What ulcer mean?
Ulcer is loss of continuity of skin on mucous membrane due
to... You
You
mentioned peptic ulcer and leg ulcer. What leg ulcer you know?
Venous ulcers, arterial, and neuropathic.
Okay. What is the character of venous ulcer?
It has... it mainly is the site at the greater area.
Okay.
The shape is irregular.
Okay. Edge is?
Edge is
it's sloping edge. Usually sloping edge surrounded by area of
granulation tissue. Surrounded by lipodermatomatosis.
What is lipodermatosclerosis?
Deposition of hemosiderin due to
so why this hemosiderin come? Because of
insufficiency of the venous system.
So mean venous hypertension. So venous hypertension can cause rupture of venules or capillaries, and hemoglobins come out, engulfed by macrophage, make hemosiderin granule, and make this color, what called lipodermatosclerosis. And or can have venous ulcer like this picture, sloping edge, can be infected, can be healed, can be granulation tissue. How to treat the venous ulcer?
By correct the underlying cause first.
Okay, and yes.
And dressing, grafting.
What is the layer of dressing you make it?
Layer?
Layer. It is four-layer dressing. The first layer is non-adherent. Okay. I think grafting is not good idea, but you can done in rare case, but it's not a good idea. So I ask you about leg ulcer. You mentioned venous. What other leg ulcer?
There is neuropathic.
Neuropathic in diabetic patient, for example. What else?
Arterial ischemic, which is
Arterial. What is the character of edge of arterial ulcer?
It is present mainly in the first metatarsal head. It is age is age maybe necrotic.
Right angle or bunched out, like have bunched out area, like right angle. Okay, it's a malignant ulcer can occur in leg.
Yes, after chronic long-standing ulcer.
Okay, so we have venous ulcer, we have ischemic ulcer, we have diabetic or neuropathic ulcer, and we have long-standing venous ulcer can be malignant. If this is malignant, what type of malignancy?
Squamous cell carcinoma.
Squamous cell carcinoma. Okay. All right. Thank you. So, doctor, well done. Of course, you can see in the pathology, you jump from topics to topics. So you can start it by peptic ulcer, followed by leg ulcer, from venous to ischemic, and just a small, short question. And usually the examiner interrupt you because they have a lot of question. He don't need to lose the time. So usually he asks you simple question because have about 20 questions he need to ask you in 9 minutes. Okay. If you have something you found it is not logic or you don't do in your practice, don't tell us in exam, because this is affect your professional mark. Professional is we have an exam knowledge part and the professional part. Knowledge part is like you have 1 mark in each. If you answer wrong, you have 0. But if you say something unprofessional, we remove mark from professional, which is 4 mark, for example, in substation. Okay. All right. Any question before we go to the next scenario? Okay. Anyone not disagree for screening to be at age of 16 in Japan? I know that it in all your resources, but actually it is for oncogene study, not for OGD. Okay. Thank you, Dr. Salma. What we have now is a simple case, maybe common, is a 35-year-old man complain for pain in the right iliac fossa, blood test show marked leukocytosis, diagnosed as acute appendicitis, has a history of mitral valve replacement for rheumatic heart. Okay, so anyone? Okay, I think Dr. Abdul Rauf, he elevate his hand. Dr. Abdul Rauf, you can, okay, all right. You can start, just take a look for the scenario, and after that I ask you.
Okay, doctor.
Yes. Okay.
Okay.
Okay. You can start or have question.
No, okay.
Okay. So what's your diagnosis? Although it is written, but what is your diagnosis?
Appendicitis.
Acute appendicitis. So what is the problem in this patient?
The problem in this patient that she have a rheumatic heart and valve replacement, which will make a problem for anesthesia and for.
What is this the problem? Give me 3 problem. Like what?
Like what patient will have a fixed cardiac output because of the mitral valve replacement will cause ischemic heart and
No, it is not necessary to have ischemic heart. It's not necessary. Okay, in this patient, in any patient with artificial valve, you're afraid from which disease?
infective endocarditis. Okay.
So you are afraid from infective endocarditis first. Second, this patient most probably on which medication because of the valve?
It will be on anticoagulant.
Oral anticoagulant. And second problem, use diathermy. So you have three problems now. Patient on oral anticoagulant, patient can have infective endocarditis, precaution for diathermy. So we start by infective endocarditis. So this station is very common because they need to ask you about infective endocarditis. What is the cause of infective endocarditis? What is the causative organism?
Causative organism of infective endocarditis will be Staphylococcus aureus and Strep viridans and fungus like Candida.
So if you don't mention fungus, usually we draw this picture to you. This is called the hyphae. And what is this? It is for fungus. So as you mentioned, it is correct. So can be strep, it can be staph, can be fungus. What is the hand manifestation of infective endocarditis?
Hand manifestation of infective endocarditis.
Yes.
Maybe ossular nodules, genuine nodules, or splinter hematoma.
Or a splinter nail hemorrhage. Okay. What is the cause of rheumatic heart disease in general? Why is some patient, it is not common now, we are lucky, but why in the past rheumatic heart is very common?
Because of hematogenous spread of bacterial infection, like in oral infection or
you mean that the patient have tonsillitis, but it is not a spread. If a spread of infection, we call it bacteremia or septicemia. But this is infection is not affect the heart. Why is this staph or strep affect the heart, or sometimes the kidney? This is autoimmune response because the sequence of the amino acid on the some bacteria is equivalent or equal or mimic the sequence of amino acid in heart valve in some patient or kidney tissue in other patient. Okay, so this is considered as autoimmune disease. Okay, all right.
And in this question, I know that answer the assembly of the antigen of bacteria and the autoimmune, but I didn't relate that the question asked about this information exactly.
The question is asked what is about the cause of the rheumatic heart.
Okay.
Okay. What is your answer? What you think is the answer?
I know that answer. You doctor said that the assembly of antigen to the amino acids of bacteria, but
Yes.
I talk about the cause of rheumatic heart in general, maybe congenital, maybe risk factors also.
No, it is it is a risk factor for infective endocarditis, not rheumatic heart. Infective endocarditis can occur in congenital heart disease or rheumatic heart or in the what we called bicuspid aortic valve. This is the causes of infective endocarditis, but not the causes of rheumatic heart. Okay. All right. It is important. One of the problem of facing exams, usually the student have a sequelae of the questions they brought it from recall, and they think we ask the same question, and usually they answer different answer, and this is also one of the cause of failure in exam. So don't think that the station you in your mind is the same station I asked you in exam. Even this.
Okay.
Because every exam have the same sequence. We have many versions for each station. All right. So we mentioned that it is immune disease. And what is the risk factor cause infective endocarditis? This is the next question you need to answer. What is the risk factor of infective endocarditis?
Congenital heart disease like bicuspid stenosis, artificial heart valve.
What you mean by cuspid stenosis? What you mean by cuspid stenosis? What you mean? Most of the students say that, but we don't know what it means.
By cuspid stenosis has degenerative changes of the valve, makes sclerosis and stenosis.
No, you mean the bicuspid means that have two cuspid.
Yes.
And what is supposed in this aortic valve? How many cuspid in the aortic valve?
Semilunar cuspid.
No, it is 2 or 3. Okay, don't worry, no problem. It means that is have anomalies, so become bicuspid valve. Okay, no problem. Okay, artificial heart valve. What else?
Cardiac device, pacemaker, or
or rheumatic heart. Cardiac device, now we have intracardiac defibrillator or intracardiac device. Okay, what complication of the infective endocarditis?
Complication of infective endocarditis may be sepsis, maybe embolism. Vegetations of the valve will lead to an embolism, like pulmonary embolism or arterial embolism. It will lead to.
All right. So, what type of tissue matching and heart transplantation?
ABO group and HLA group.
What is LHA mean?
Human leukocytic tissue.
Human leukocytic antigen. It is found in which cell?
Lymphocyte.
No. Human leukocytic antigen found in all cells of the body. It is discovered in leukocyte, but is found in the all cell of the body. Okay. What complication if you give a patient immune suppression drug? What is the complication? What is the common immunosuppressive drug you give to the patient?
Immune suppressive drugs like steroids.
Steroid. What is side effect of steroid?
Side effects of steroids may be endocrinal, like hypertension, diabetic, and immune compromised patient, osteomyelitis, osteomalacia.
It is for long run, but in short can affect the wound healing and all this. What infection can occur if the patient or the patient is immunocompromised?
What
infections can cause if the patient is immunosuppressive drug?
Infection like candida, like fungal infection, viral infection, bacterial infection.
Okay, so mean opportunistic infection, and it can be parasite also like pneumocytosis carinii or some tumor like angiosarcoma. All right, so in this patient, back again to the patient, what is the therapy precaution for this patient?
The precaution, firstly, if the patient has any metallic replacement of
no, like, of course it is metallic valve. It is a mitral valve. It is a metallic here now. Okay. So what is the precaution?
Precaution, firstly, I will use a bipolar dithyramine or
That's good. Use bipolar dithyramine. Okay. So if use bipolar dithyramine, where you put a patient blade?
In the right side.
No, it is wrong answer.
In the left side.
No, wrong answer also.
No blade.
No patient blade. You mentioned it is bipolar, so it is no patient blade. Okay. All right. So you need to be also. This is also for what you know it from recall or from the student. I don't ask if you use monopolar what you put. Is this different question, different station? Okay. So this patient an oral anticoagulant. So what you will do for that?
I will first check for the efficacy for oral anticoagulant.
How to check the efficacy for it? By
INR, international.
What does INR mean?
International normalization ratio.
It has been what and what? Any ratio must be between two things. It is ratio between what and what?
Between prothrombin time and clotting time.
Between prothrombin time and control, not clotting time. Prothrombin time is what? What is your prothrombin time? What is normal prothrombin time?
15 seconds.
15 seconds. Okay. All right. So you stop oral anticoagulant guided by INR. Your aim to reach what?
To reach INR between 1.2 1.4 by bridging.
You mean that less than 1.5 to be no have no bleeding. Okay. So you mentioned this patient in oral anticoagulant. This oral anticoagulant act on which pathway?
It act on intrinsic and common pathway. I have heard you, doctor, talking about this question once before. You said that in the physiology books it written extrinsic and common pathway.
No
but,
problem. It's up to you. We consider all is correct in exam. For me, we consider all is correct in exam. Okay? But
Okay.
because you know the answer, in your physiology book, what you found in your physiology book?
I found that extrinsic and the common pathway.
Okay, this is what you teach in medical school because in our exam we teach you background. Background is what you learn in medical school, not what you learn from me or from other resources. But if you mention intrinsic, extrinsic, common pathway in exam, we accept it for you, but no problem. Okay, and this is factor 2, 7, 9, 10. Okay.
Yes.
What you need to say in exam, up to you also. What mechanism of heparin act in which pathway?
Act on common pathway and common pathway.
And intrinsic. So what is the antidote of heparin?
Antidote of heparin is protamine sulfate.
What is the antidote if the oral anticoagulant if you need to stop faster?
For the fresh frozen plasma, platelet, and the cryoparticipate.
Fresh frozen plasma, yes, okay. It is prosthrombic concentrate, not cryoprecipitate. Cryoprecipitate is factor 8. It is used in other topics. Okay. All right. What is Clexane?
Clexane is one of types of heparin, like unfractionated low molecular heparin.
All right. So what you give to the patient? What is the route?
I will bridging of the oral anticoagulant. I will stop warfarin and bridge
No,
the
the
patient
route.
to.
Just give me the route is one word. What is the route?
Clexane is used
Subcutaneous. How to give it subcutaneous? What is the route to what is the way to give subcutaneous?
Directly using the syringe. It's easy to use by angle.
What mean by that directly? It means that 90 degree.
90 degrees.
Okay, you understand, or you need to show you the picture?
No. I saw this before.
Okay, all right. So, okay. Thank you, doctor. I just need to explain with you, Dr. Abdurraouf, again. When we have a difference, if I say something wrong or you say something wrong, our reference is my academic book like anatomy book, physiology book, pathology book. All right. I know that in the most of the book written about what is called, we ask about warfarin is written at, it is affect intrinsic, extrinsic, and common. And even if you Google it, you can find it is. But when we have a debate, we back to our physiology book. So when you back to your physiology book, you found it is what?
Extrinsic and the common pathway.
Okay, common pathway. Okay, so you know the idea? Because we
yes,
don't teach you what is written in Google. Google is not a medical book. Wikipedia is not a medical book. Okay? What is your opinion? What you think or what you need to comment?
I think from my point of view that warfarin work on vitamin K factors, which is 1972, 7 and 9 in the intrinsic pathway 10.
Yeah, I understand you. Okay. I agree with you. Okay.
Okay.
But the physiology people is agree with you or not?
Not.
Okay. All right. So you know that we have big textbook like Gannon, Guyton, and all this, so we depend on it. No problem. Okay, don't worry. Just to know that it is 27910. No problem. Okay, thank you. We have another case. I think we're about to finish. This is case is very common also, and it is about 45 years old woman, tennis trainer, complain of pigmented skin lesions in right thigh, histopathology of excised lesion proved to be malignant. Okay. All right. Thank you, Dr. Abdel Raouf, by the way, and thank you for your comment. And it is important also, if you hear something from me or from any other stuff or any other book, just to go to the original text and can what is called evaluated, or can see maybe in the future we change it. Don't worry. Okay. Anyone need to take this station? But by the way, I was in the last exam, I think in Sri Lanka. I found all the students say interesting, and it is first time to hear about this. But after we found all the students say that, so make it okay. We say okay, no problem. All right. Anyone need to speak about skin tumor? It's very common disease in UK. Very common, very important topics, by the way. Dr. Salma, you can start again. Don't worry.
Okay, doctor.
Okay, can. So you can see the scenario. It is clear. It is what? Yes, can.
Doctor, can you hear me?
Yeah, yes. Okay. So what's your diagnosis?
Okay. My diagnosis is a malignant melanoma.
All right, I agree. So what type of melanoma you know?
There is acral and superficial spreading and lentigo maligna.
Okay,
and
and
nodular.
melanotic melanoma. What is the common site of melanomas?
And skin. And
Skin, of
also
course,
in the
expose the area, and
after skin, a mucocutaneous junction, maybe in the eye.
okay, eye, anus, vulva, esophagus, subangle. What is the predisposing factor of the malignant melanoma or melanoma?
Exposure to sun, certain genetic anomalies like xeroderma pigmentosa.
Yes, dysplastic nevus, junction nevus, and freckle. Freckle is a character of skin in some people in Ireland, like Irish people. They have some freckle. Okay, all
Yes.
right. So how to stage melanoma? Just give me the names.
Breslow.
Breslow and the Clark level. All right. So what is good in Breslow? What is bad in Breslow? Not in detail, just what's the high, what is the low?
Good, that is thickness is low.
Okay, low, what it mean? It is 0.78. It is good prognosis, mean 98, 5-year survival. And the bad is 3.5. Consider that the thickness of the skin maximum is half centimeter. Clark level have 5 level. First level in epiderm, level 5 in subcutaneous. So we don't ask you about detail, but at least you know the bad and the good. All right. So which melanoma is bad prognosis?
Amelanotic and nodular.
Amelanotic because difficult to diagnose. And which melanoma is good? Not good, like good prognosis.
Superficial spreading.
Superficial, of course, superficial. Okay, so the bad is nodular and the melanotic, and the good is superficial. What is the method of spread of melanomas?
Lymphatics, blood, and local.
Local, what is called satellite ganglia. What is the origin of melanoma?
Melanocytes at the basal layer of epidermis.
No. Okay, don't be so clever. Melanocyte is okay. If it is a basal layer of epidermis, it's called the basal cell carcinoma. It is only melanocyte. Okay? What is the shape under microscope?
It is large cells with like an inclusion bodies, dark pigmented.
Dark pigmented nucleus, you mean that increased nuclear cytoplasmic ratio, deeply stained or hyperchromatic nucleus, polymorphism, and this is the character of any malignancy. So if you ask you an exam about any malignancy, it is a fixed character. Increased nuclear cytoplasmic ratio, hyperchromatic, polymorphism, increased mitosis, deeply stained nucleus, abnormal melanocyte. How to treat melanoma?
By excision with safety margin.
Usually safety margin minimum is
0.5
half centimeter, 0.5 centi or 5 millimeter. What other malignant skin tumor you know?
Squamous cell carcinoma, basal cell carcinoma.
So from where basal cell carcinoma arise?
From the basal layer of
okay,
the
from the basal layer. Okay, what is the difference between basal and the other skin tumor?
It is locally malignant.
What you mean by locally malignant?
This probability to metastasize and slowly growing.
Okay, and not spread. I just show you the picture just for superficial spreading. Patient also have freckle. Melanoma patient also have freckle, nodular, satellite nodule, and acral lentigo maligna occur in the soul. So you mentioned that basal cell carcinoma, back to basal cell carcinoma, is a local spread. What is the common site of basal cell carcinoma?
At the face, in a line extending from the ear lobule to the angle of the mouth.
All right. So what other cancer you mentioned? Squamous cell carcinoma. What is the cause of this?
Cause is exposure to sun, any predisposing factor like xeroderma pigmentosa also.
And you mentioned an ulcer, long-standing ulcer. Okay.
And
by the way, Dr. Salma, when you say exposure to the sun, it is exposure to the sun to people who wear fair skin.
Yes.
Because people in Africa is exposed to the sun, they don't have skin cancer. So it is exposure to the sun for the fair skin people, all European people. Method of spread of squamous cell carcinoma?
Blood, lymphatics, blood, and local.
Okay. What is keratocanthoma?
Keratocanthoma is a benign lesion present as a nodule with central ulceration.
No, it is central, not ulceration. It is central keratin, not ulcer. It's depression and full of keratin. This is a picture. It is mimic squamous cell, but it is benign, not precancerous. It's called the keratocanthoma. Okay? All right. So, because still in the stations, we have a time. So, we go to the next station with you.
Okay.
And this is about the thyroid. It's very common also. 25 years old woman complain of goiter after performed right hemithyroidectomy, histopathology, excision mass proved to be papillary thyroid carcinoma. If you look into this script, patient is 25, so young.
Yes.
And they have papillary thyroid carcinoma, which is occurring age of 20. And they have right hemithyroidectomy. Usually in the papillary, some prefer to have total completion or total thyroidectomy. Okay?
Okay.
So we start by, of course, it is papillary thyroid carcinoma. So in this, what is the next step?
It is an MDT approach, complete excision of the
What is
thyroid
MDT
gland,
approach you mean?
meaning collaboration between the surgeon and the oncology team.
Okay, of course, if you exam, don't say abbreviation, except something very common like ETLS or something like that. Okay, so what is the treatment?
A complete excision of the thyroid gland with or without lymph node dissection.
All right, okay. So what other thyroid tumor you know?
There is follicular and medullary and anaplastic.
What is the method of spread of each?
For
No,
for
you need to
follicular?
add, and what and after that, what you need to add? I stop you.
No, I will start to tell the methods of spread just.
Okay, what is the method of spread?
For follicular, it's spread mainly by blood. For papillary, it's lymphatic first, and for medullary, lymphatic and local, and for anaplastic, mainly local and
Okay, okay. Or what and what?
also local and lymphatics and blood for anaplastic.
Okay, what origin of medullary thyroid carcinoma?
Parafollicular C cells.
Okay, so what is multiple endocrine neoplasm type 1?
It is a group of hereditary disorder related to endocrinological problems, parathyroid hyperplasia, pancreatic tumor, for example, insulinoma, and pituitary tumor.
What is multiple endocrine neoplasm type 2?
It is a combination between pheochromocytoma, medullary thyroid carcinoma, and parathyroid.
What is the tumor marker for medullary thyroid carcinoma?
Calcitonin, and also carcinoembryonic antigen may be considered.
Calcitonin, I agree. Carcinoembryonic antigen is more specific for medullary thyroid carcinoma or non-specific?
It is less specific.
Okay, so don't say something you have query about it, so why it is not specific, and ask you some details. Okay, so you know that the examiner usually is a pathology or surgical pathology. So if you go to in his court, you will be in trouble. What is the tumor marker of pheochromocytoma?
It is in blood. We have metanephrines in urine, vinyl mandelic acid.
What other tumor marker you can find in urine?
Pence-Johnson proteins in multiple myeloma.
Yes. In carcinoma tumor, what you found?
5-hydroxyindole acetic acid.
Yeah, 5-high or 5-indole acetic acid in the carcinoma tumor. Where is carcinoma tumor arise? From which area? Or which organ?
Mainly gastrointestinal tract,
mainly
ileum,
which organ? Which
appendix.
organ? Appendix. And usually in which part of appendix? In the tip of appendix, usually in the tip of appendix. So if it is in the tip of appendix, suppose you have a surgery, you did appendectomy, send it for histopathology and found it is carcinoma tumor in the tip of appendix, and appendix is 5 centimeters. What else you need to do?
Can you hear me, doctor?
Yes, I hear you. But if the patient have carcinoma tumor in the tip of appendix and the appendix is 5 centimeters, what is the next step?
The tumor is 2 millimeters?
No. The tumor is in the tip of appendix and the appendix is 5 centimeters.
So I will remove the appendix.
You already you know the result after you remove the appendix. Histopathology come after surgery by 1 week or 2 weeks. You ask the patient to come for another surgery or not? No further surgery.
No,
Thank you.
No.
Okay, so back again to your question. What is the oncogene in multiple endocrine neoplasm type 2?
Type 2, it is red oncogene.
RET, red oncogene. Can lymphoma occur in thyroid?
Lymphoma in thyroid, yes, but it is secondary.
Secondary to what? Hashimoto. So you can see the tumor of the thyroid follicular spread by blood, papillary lymphatic, occurrence 20, anaplastic medullary. Common is papillary, or thyroid tumor is rare, but the common is papillary. We don't consider lymphoma as a proper thyroid tumor because it is occur after Hashimoto. This is also papillary and is multifocal, so this is why only in papillary we need to have total thyroidectomy. In other, maybe just have hemithyroidectomy. Hemithyroidectomy means remove the right lobe or left lobe with isthmus as a safety margin, followed by radioactive iodine. This is multiple endocrine neoplasm type 1, parathyroid adenoma, pancreatic pituitary adenoma, multiple endocrine neoplasm type 2, medullary thyroid carcinoma, pheochromocytoma, parathyroid adenoma can be attached or associated with neuroma or parphenoid. Oncogene for multiple medullary thyroid carcinoma is RET or proto-oncogene. What is Hashimoto, doctor? We're back to you again. What is Hashimoto disease?
It's a type of inflammation, autoimmune thyroiditis occurring in the thyroid gland.
What is the character if the patient have Hashimoto, who usually complain of the swelling in the neck, and this swelling is what?
Is painful.
Painful swelling. Okay. What is the value of ultrasound in thyroid swelling?
It differentiates solid from cystic cyst.
If it's cystic, what you need to do?
I find needle aspiration cytology, so it guide with this.
Okay, so in the ultrasound, you look, it is cystic or solid, and what else you're looking in the neck?
And lymph nodes.
Lymph node, because it is in papillary thyroid carcinoma. After thyroidectomy, if you injured external laryngeal nerve, what happened to the patient?
External laryngeal nerve, the patient will lose ability to reach a high-pitched voice.
So which muscle is innervated by the external laryngeal, which is branched from superior laryngeal nerve?
Cricothyroid muscle.
Cricothyroid muscle, okay. All right, what is the cause of sudden increase in thyroid cyst?
Hemorrhage. Also
hemorrhage,
maybe,
yes, or cancer, but usually hemorrhage, especially after fine needle. What is Graves' disease?
it is a primary thyrotoxicosis in which there is an antibodies resemble the action of thyroid stimulating hormones.
Okay. All right. Of course, this Hashimoto can complicated by lymphoma. Okay. You see this picture, doctor?
Yes, it's orphan Annie eye.
Orphan Annie eye. It is what? Indicated what?
Characteristic for papillary thyroid carcinoma.
Yeah. So they have orphan Annie or empty nucleus cell, but actually the nucleus in periphery and microcalcification, what we call this Samoma body, is a characteristic of papillary thyroid carcinoma, which is occur in young people. Okay, so I stop here. I just stop sharing. Thank you. But what I need to tell you, okay, so I